our review for today, the first objective for this 2 hours from the endocrine system in the pituitary or pathology of the pituitary gland corresponds with the most common benign tumor of this gland, which is the prolactin. For some reason, well, everybody can hear me well, right? I didn't, huh? Good. Okay, prolactin. Please, definitely, this is the #1 objective. There's no such other tumor that is that abundant like the prolactinoma or lactotroph adenomas. The rest of them has been common in our last lecture. They are not that common. So clinically, you have to be ready for diagnose this particular benign neoplasm. Very, very common, excess of prolactin, and these are the signs and symptoms that you're expecting in your patients. You already know the physiology of the prolactin, so amenorrhea, vaginectoria, infertility, clinical scenarios, questions like your life professional is going to bring for you. In case of the somatotroph adenomas, they're not that common, but giantism, if it's an excess of growth hormone, it's important also to know that. Clinically, how can you advise, how can you diagnose a patient with excess of growth hormone? If it's an adult, acromegaly. So please be familiar also with the clinical pathological manifestations of giantism and acromegaly, which is an excess of growth hormones. All of those clinical scenario questions are very easy to diagnose in the proper setting. Okay? Well, the hypopituitarism, the maximum expression of this entity is actually, I have here for you. I do always recommend read the whole package, read the whole information that I'm providing for you. Specifically, we're going to follow the objectives that their program for your optometry students, but I will be using every single entity in your exam, okay, for any questions and kind of distractors for you, so that demand for your knowledge of any other pathology or disease which is not a proper objective for your course. Is that okay? So please do read the package. So well, hypopituitarism, specifically a very well-known syndrome, Sheehan syndrome. It's one of the, as I said, maximum expression. Everything is failing here, and you have to be ready for this clinical scenario question also. And all the affections in the pituitary gland. I mean, this is a necrosis of the pituitary gland, and one of the most predisposing conditions is during pregnancy, during childbirth, in front of a hypovolemic shock. The pituitary gland is highly enlarged and very susceptible to this type of necrosis. Okay, so please be ready for the clinical manifestations of patent hypopituitarism in the Sheehan syndrome also. Okay, all of this genetic analysis will be used as you know, distractors, so you have to be ready for them also, and as well as Turkica, etc. Well, in the pathology of the posterior pituitary gland, ADH hormone, the antidiuretic, sends diabetes insipidus. Are you ready to diagnose a clinical scenario question in the patient that is suffering of insipid diabetes? Okay, this is basically the objective of this lecture. Okay. In the thyroid gland, okay, in non-toxic goiter cytosystem that I use all the time in clinical scenarios, do not forget a non-toxic, it's euthyroid individual patient. We just have the thyroid enlargement. They are seeking for medical attention for just this unique sign, and we do have initially, primarily, the normal function of the thyroid gland. So pay attention to this. Okay, and the non-toxic goiter. Since she was otherwise asymptomatic and many in her community had the same problem, she did not seek medical attention. It's just an enlargement of the thyroid gland. Okay? So please be familiar also with these clinical features and complications that are correspondent or this non-toxic goiter. Sometimes, unfortunately, they're coming with such complications like, for example, the pressure in the veins and all of these pictures that I used for you in your lecture. Okay? Signs, non-toxic goiter. I would like, please, that you make the clinical pathological correlation between the multinodular and non-toxic goiter, what kind of patient preference will become more affected, and the multinodular pattern at the same time in the pathology and morphology. If this diffuse enlargement without this multinodular, if there will be irregular, follicles and irregular nodules, then you're expecting patients that are older than 50 years old. This is classically what's coming with a non-toxic goiter. Good? So far, any question? All the time, please. Clinical scenarios questions. Okay? Which is how the life is going to work with this in your profession. Very important. Okay, diffuse non-toxic goiter, multinodular non-toxic goiter, clinical scenarios, clinical signs and symptoms in there, and the morphology. Well, the hypothyroidism, cretinism, congenital hypothyroidism, this, okay, I'm pretty sure it's 5% of the clinical scenario question. With these characteristics, you will be ready to diagnose, and you will be ready to tell me what's the hormone that should be absent, okay? If it's a cretinism, or if it's an adult, hypothyroidism in the adult, it's coming with different clinical pathological manifestations also. And hyperthyroidism, Graves' disease, this is one of the most common autoimmune disorders, very important objective, not just the signs and symptoms that guide you to the diagnosis. At the same time, you have to be ready for the pathogenesis. Okay, the pathogenesis, there are several factors, risk factors for the disease that specifically do not forget these anti-TSH receptor antibodies. They're acting as an agonist, so we will have more production of definitely hormones. The thyroid hormone secretion, they're acting as agonists with the TSH receptors. Okay? Please, pathogenesis of Graves' disease plus clinical pathological manifestations is a very important objective. Do not forget exophthalmos, autoimmunity, all of these characteristics that are typical of Graves' disease. I took my time looking real clinical scenarios, cases for presumptive signs that if you do not find exophthalmos in this patient, you have to doubt about Graves' disease. Okay? More exophthalmos, dermopathy, pathogenesis. Don't forget pathogenesis. Well, in chronic autoimmune Hashimoto thyroiditis, pathogenesis, please. This slide is really important, and I would like that you make the correlation or the differences between the pathogenesis leading to a hyperfunctioning thyroid in Graves' disease and a hyperfunctioning thyroid in this case of Hashimoto thyroiditis. Okay? Well, in thyroid neoplasia, we mentioned here in class different type of possible cancer of the thyroid gland, but papillary thyroid carcinoma, as you know, represents the most common, most abundant, sporadic type of thyroid cancer. So papillary thyroid carcinoma, fortunately, 95% of all of these thyroid nodules are benign. But if they're cancer, pay attention to papillary thyroid carcinoma. We do have more anaplastic thyroid carcinoma, follicular, but papillary thyroid carcinoma pathogenesis, risk factors. Let me show from here. You see 80 to 90%, even more than that. Please, etiology, molecular pathogenesis, which are the risk factors that we have in our patients, the radiation, take external radiation to the neck. Do not forget the age of the individual. As younger is the patient, we will have more uptaking of the radioactive iodine. That's another important risk factor to take in consideration. And well, these genetic mutations or somatic genes that are in relation with this exposition to radiation, red proton gene, the BRAF mutation, and RAS mutation. So please, molecular pathogenesis and risk factors in papillary thyroid carcinoma is a really important objective for this lecture. Orphan high, morphology, this is pathology. So don't forget the ground glass or orphan in the setting of a history, physical examination indication of papillary thyroid carcinoma. Good. See all of this clinical pictures. So far, it's important to follow, just to make a checkpoint here, prolactinoma, the lactotrophic adenoma, which is the most common type of benign neoplasm in the pituitary gland. In the hyperfunction of the pituitary gland, the Sheehan syndrome, which is the extreme manifestation of all of this hyperfunctioning. Do not forget signs and symptoms: pregnancy, childbirth, complication with the hypovolemic shock. This is the most susceptible condition for suffering the syndrome itself. And well, papillary thyroid carcinoma, we already mentioned all of the, yes, I think, yes, we're covering every single chapter here. So, parathyroid glands. Parathyroid glands, parathyroid adenomas. And in the parathyroid adenomas, in the primary hyperparathyroidism, is the parathyroid adenomas, the hyperfunctioning adenomas, even more than 80%. This is the more common etiology for this entity. Okay. Well, as I said, we're going to be using all of these syndromes. Well, in the systemic or in the secondary hyperparathyroidism or the hyperfunctioning of the parathyroid glands, also you have to be familiar with the systemic manifestations in the setting of the hyperparathyroidism for identifying the patients. So in adrenal gland pathology, Cushing syndrome, okay, hypercortisolism, Conn syndrome in the hyper or excess of aldosterone. This is a basic physiology of the endocrine system. And please, the Addison disease, I mean, etiologically, you have to be familiar. When you're talking about Addison disease, this is a primary chronic adrenal insufficiency. Okay, acute adrenal insufficiency and congenital adrenal hyperplasia. Etiologically, who's leading to that particular entity. Or if you're talking about, for example, the adrenal hyperfunction, chronic corticosteroid administrations, okay, it's the number one cause of this syndrome. Okay, Cushing disease, Cushing syndrome. Etiology. In case of the adrenal glands, every single etiological principle that is behind. And please, in this case, that we have the congenital adrenal hyperplasia due to the recessive disease deficit of the 21-hydroxylase deficiency. It's another important objective for this lecture. Okay. Well, in pheochromocytoma, I think was the last topic that we discussed in class. This is a benign tumor of the chromatin cells. This is the medulla in the adrenal cortex, and all of these clinical pathological manifestations that help you to identify these patients, okay? So basically, the questions like your real life as professional are gonna come with the clinical scenarios, manifestations, okay? I think it's the easy ways to diagnose. There are some particular entities that I mentioned, be familiar with the pathogenesis, because this is, there are risk factors that you need to identify in a proper interrogatory and physical examination of your patients, like, for example, papillary thyroid carcinoma and so on, okay? And Graves' disease, the pathogenesis, good. I think there's not that much information, it's just 2-hour lectures or endocrine system, and it should be okay. If you read that package, since the very word to the bottom part, do not forget, there's a lot of important information that we did not include, so you deserve to read the whole package, okay? But just concentrating the objectives. Do you have any questions? No? Yes?
Are we responsible for the pancreas, the pathology?
Yeah, definitely. The endocrine pancreas. It's just Dr. Jones was the one that taught this, instructed to you this lecture, so I could defer to. He went over about that, right?
What's that?
The Dr. Jones, yeah, but you are responsible for it. Yeah? I did not teach this lecture to you, but do you have any question in relation with that? It's basically, do not forget the diabetes mellitus, type 1, type 2, and the pathogenesis. I mean, clinically, they're pretty similar sometimes, but you have to look at the age of the patient, the autoimmunity, okay, pathogenesis in diabetes mellitus type 1, and the risk factors. I remember I posted in your Blackboard. It's not in here. Yes, I posted in your Blackboard a table that is describing the pathogenesis and I mean the differences between diabetes mellitus type 1 and type 2 in relation with the etiology, pathogenesis, clinical signs, evolution, age of the patient, genetic predisposition or not, okay? Any other questions? Okay, thank you.